Hey, perceptual problems. So Lila's an 80-year-old widow. She's worn glasses for many years, and she was diagnosed with chronic open-angle glaucoma. So what's that mean? The treatment is actually timoptic, which is timolol, which is a beta blocker. That's interesting. And she is still having difficulty reading and watching TV. She also has cataracts, and those are going to be removed now. She did have a TIA 8 years ago, and she's currently on an aspirin a day, a regular strength aspirin. Her visual acuity in her left eye, OS is oculus sinister, her left eye is 20/50, and it's 21/50 on the right eye. We're hoping to make that better. So her intraocular pressures, the normal is 12 to 20. In her right eye, it's just a little bit elevated at 21, and her left eye, it's 17. So that's actually the definition of glaucoma, is elevated intraocular pressure. So she does have some mild glaucoma, even with her treatment. So what happens? You have a production of aqueous humor. So the aqueous humor is produced. It circulates in the anterior chamber in front of the iris. This is the pupil, which is a hole. And then it goes down into the trabecular meshwork, and then it excretes out into the nasal cavity. That's actually where it goes. The vitreous humor, which is back here, is mostly the same vitreous humor you were born with. Obviously, your eyes are bigger, so it has produced more, but it really is not something that is fixed or changed. This is why if you get a floater back here, it'll often be permanent. So the posterior chamber doesn't really create fluid, although as we know, it does as you grow. So why did the pressure increase? Well, there's two real reasons that the pressure increases. One is the narrow angle glaucoma, in which the angle of that anterior chamber will narrow right down and block the exit. The other is because the trabecular meshwork will actually kind of block up over time. And that's usually the open angle or chronic. The fold over is acute. It's very painful. They'll get a fixed point mid dilated pupil, and then they'll have so much pain they usually go to the hospital. The chronic open angle glaucoma usually builds up gradually, so gradually that they have little or no change in their vision. Some people will talk about halos. They will usually develop halos around things. The Leonardo da Vinci, and when I mean Leonardo da Vinci, I mean Vincent van Gogh, painting Starry Night is often thought to be related to his glaucoma. Long term, the increased pressure will damage the optic nerve. It damages the outer portion first, which is why you get those halos. So again, that's where the flow goes, is down here. And if these things block up, less can get out and the pressure goes up. So again, slow clogging or folding over the iris. This is narrow angle glaucoma. This is open angle. So we said you get a painful red eye, a fixed midpoint pupil, and it is always sudden onset. It's a severe medical emergency. They need to go to the hospital immediately. We'll give them a medicine that decreases the amount of fluid in the body, which actually decreases the pressure in the eye. We'll block an enzyme called carbonic anhydrase, which is what neptazane does, and it will stop the production of aqueous humor. And we'll also try to pull the iris away. A miotic is a medicine that constricts the pupil. A mydriatic, with a D in it, dilates the pupil, so D for dilate. So open angle, clogging of the drain, not all the holes clog. And sometimes what we'll do is we'll do drops that'll keep the pupil small. Beta blockers do that, and that's why this lady's on timoptic or timolol. And cholinergic eye drops, something like pilocarpine will do this as well. Anticholinergics, of course, will dilate the pupil, and will potentially worsen glaucoma. Laser can open up those clogs. We can use the carbonic anhydrase inhibitors for open angle as well, although we don't use them as much. And there is surgery that can actually open up or even remove that trabecular meshwork. So a cataract is when the lens, so the lens is right in front of the iris, and that lens focuses. It either stretches or contracts to focus the vision onto the back of the eye. It's focused there. It actually shows up upside down, and then your brain actually flips it back over. And what happens, though, is that if this lens clouds up, you'll actually develop blurring of your vision and decreased vision. If it's bad enough, you'll actually be partially blind or even completely blind. And so what we do now is we remove that. What kinds of things cause the lens to cloud? Diabetes, certain medications, ultraviolet rays from the sun, which is why we encourage people to wear sunglasses with a good UV blocker. Photocopiers actually put out a pretty good amount of UV light as well. And trauma can cause cataracts as well. So we basically remove the lens and replace it with a plastic one. And let's move on to hearing loss. So hearing loss occurs in about 40 or 50% of the people over 75. And those of us that listen to Aerosmith as teenagers often have it worse. It's amazing to me that Aerosmith is still performing, but that's a whole nother discussion. You can actually get a conductive hearing loss or a sensorineural hearing loss. So conductive is when the bones or something is not conducting the sound to that inner ear. The sound is actually perceived in the inner ear, in the cochlea. And so if the conduction doesn't get all the way in there, you're not going to hear anything. If there's a problem with the actual cochlea itself or with the nerves, especially the 8th cranial nerve, the acoustic nerve, then you'll have a sensorineural issue, and physical exam is slightly different, as well as the approach. There's no medications to help this. Presbycusis is a lot like presbyopia, is as you lose your close vision as you age. Presbycusis is when you lose hearing as you age, especially in the high tones. Low tones you perceive longer. And so the hair cells, which normally vibrate, they often have a little piece of calcium on top of them as well. If this calcium gets knocked off and then blocks the way the hairs move, that can actually cause the hairs on one side to move differently than the other side, and that will give you vertigo. But that's a different discussion. Tinnitus is the sound of ringing in your ears. Now, we talk about ringing, but it doesn't have to be ringing. It can be whooshing. It's a lot of different things that it can be. But basically, you have this perception of sound or noise in your ears most, if not all, the time. Many people will distract from it, but if they sit down and are in a quiet room, they can hear it. Hearing aids will amplify sound. Again, if it's a conductive problem that the bones are not moving, it's not going to help that much. Or if it's a severe sensorineural issue, it may not help that either. But when someone has hearing loss, usually we'll send them to an audiologist. They'll do a thorough evaluation, and they'll decide whether or not they can use hearing aids. You know, we used to use them mostly for conductive, but now there are types of hearing aids that will also help for sensorineural. Otosclerosis is a specific problem in which the bones fuse. Therefore, this is a conductive hearing loss. You can use a hearing aid, or if it's severe, sometimes you even remove and replace those, the incus, the malleus, and the Santa Maria. No, wait, incus, malleus, and the stapes can actually be removed and replaced with basically prosthetic or plastic bones. You can use visual adjuncts for a hearing aid. You wouldn't think that vision is important, but especially if you've got somebody that really can't see the lips and can't get those visual cues, it can make a huge difference. You can try changing your tone. So if you are talking and you lower your voice, they're going to be more likely to hear it. Very frequently when we yell, our pitch goes up, so they're actually less able to hear that. Try to limit other noise. Many people are fine in a quiet room, but if they get in a crowd, and then rephrasing sometimes helps too, because people have missed certain letters or certain words. So drugs of the week, timolol, Neftazane and Diamox are both carbonic anhydrase inhibitors. Mannitol is a osmotic diuretic, and pilocarpine is a cholinergic eye drop.